get started?
Welcome to this EURO-NMD webinar that is organized in collaboration with the European Reference Network for Rare Neurological Diseases and the European Reference Network for Complex and Rare Epilepsies, EpiCare. We have today a webinar about the cardiac involvement in neuromuscular diseases, and the presenter is Professor Karim Wahbi. He works at Hospital Cochin in Paris, and is a university professor and an hospital practitioner of the University of Paris. He coordinates the Cochin Hospital site of the Reference Center for Neuromuscular Diseases Northeast Île-de-France, that is dedicated to the management of cardiomyopathies associated with neuromuscular and metabolic diseases and mitochondrial diseases in particular. Is a founding member of the Paris Myocardial Institute, coordinates the care, teaching, and research activities around the theme of the Cochin Reference Center, and more broadly within the Paris Myocardial Institute for dilated cardiomyopathies. Is involved in the transition clinics from children to adults with Professor Bonnet's team, and consults in the genetics department of the Georges Pompidou European Hospital, directed by Professor John Maître, for the genetic exploration of cardiomyopathies. Is involved in many international and national projects, also in registries, therapeutic trials of neuromuscular and mitochondrial cardiomyopathies, namely within FUNEMUS, the Neuromuscular Care Network for the French National Health System, and is got a participation that is frequent and in international scientific meetings, both of cardiology and sometimes also neuromuscular and neurological diseases. Thank you very much, Karim, for accepting to give this talk and this webinar. I know that you're an excellent communicator, so yeah, I'm really looking forward to hear what you have to teach us today. Thank you.
Thank you very much, Antonio, for this very kind introduction. And it's really a great pleasure for me to give this talk on cardiac involvement in neuromuscular diseases, which is a major topic and very important issue for neuromuscular patients, because cardiac complications represent, in the end, one of the most common causes of death in those patients. And I will try to show you how important it is to prevent those complications. And I will show you that a lot of therapeutic measures are really efficient to improve patient prognosis. I will start with very general aspects of cardiac involvement in patients with myopathies, and then I will go through cardiac involvement and cardiac management for some of the most common myopathies, or at least some of those with the highest risk for cardiac complications. So first of all, the general aspects. So very basically, large number of inherited myopathies are caused by mutation in a gene, and as a consequence, an abnormal expression of specific protein. And since there are really great similarities between the skeletal and the cardiac muscles, it results in many cases in the concomitant development of myopathy and cardiomyopathy, and sometimes other abnormalities. We do not have this scheme for all diseases, but this is a prominent one. Things are a bit different for myotonic dystrophy. And there are also similarities in the involvement of the skeletal and the cardiac muscles for inflammatory conditions as well, and sometimes in patients affected with dermatomyositis. So when patients have cardiac involvement, there are two types of manifestations that can be observed. The main one is an involvement of the cardiac muscle itself, called cardiomyopathy, kind of myocardial disease. And sometimes patients can also have specific electrical abnormalities. Majority of patients have dilated cardiomyopathy, which is defined by an impairment of the contractility of the left ventricle. But sometimes you can see hypertrophic cardiomyopathy, which is less common, which is seen mainly in metabolic myopathies, glycogen storage diseases, mitochondrial diseases. And less frequently, we can have a restrictive cardiomyopathy, which is defined by highly abnormal feeling pattern of the left ventricle. You can see that mainly in patients with desminopathies. Among electrical abnormalities, we can see different things, either conduction abnormalities, which are highly frequent in patients with mitral dystrophy or other arrhythmogenic conditions such as laminopathies, desminopathies. And sometimes patients can have ventricular tachyarrhythmias or supraventricular tachyarrhythmias are present pretty much in the same conditions, laminopathies, desminopathies, and some other arrhythmogenic conditions. And myocardial involvement can lead in the end to the development of heart failure, and heart failure represents a common cause of death in this population, while conduction system disease and ventricular tachyarrhythmias represent a common cause of sudden death. And supraventricular arrhythmias can also have a significant morbidity, as patients can have ischemic stroke as a consequence of cardiac thromboembolism. What makes cardiac management of patients with myopathy interesting but difficult, the fact that there are very different patterns from one condition to another. It will be impossible to present you today all the manifestations that can be seen in any inherited or inflammatory myopathy. But you can see just here, very basically, that for heart failure and electrical abnormalities, you can see very different things between those conditions. In myotonic dystrophy, heart failure is quite uncommon, but conduction system disease is very frequent. For patients with dystrophinopathies, heart failure and dilated cardiomyopathy are highly prevalent, while electrical abnormalities are not so common. And you have conditions such as laminopathies or desminopathies where you can see these two types of manifestations. And in mitochondrial disease, for example, you can see different patterns with some mutations associated with a high risk of heart failure and other mutations, a high risk of major conduction defects. So cardiac manifestations are very specific from conditions, are very different from one condition to another. One very important point is that you have a continuum in the development of both myocardial and electrical abnormalities from the very preclinical stage where patients carry mutation, they have functional abnormalities at the molecular level, but no clinical expression of the disease, to a stage where patients have very mild abnormalities, for example, an impairment of the contractility on the echo or conduction defects on the ECG. And then you have the stage where patients have significant involvement with symptoms, heart failure, sometimes syncope or palpitations. And in the end, the life-threatening manifestations, terminal heart failure, cardiac arrest, and sudden death. And since a majority of patients initially develop skeletal muscle involvement before the development of severe cardiac involvement, at diagnosis, in a majority of cases, patients, when they have abnormalities, have only mild abnormalities, which leaves place for preventive treatments, which are highly efficient to improve long-term prognosis. One very commonly asked question is there a correlation between the severity of skeletal muscle involvement and cardiac involvement? Well, I would say that there are different aspects at the population level. If you take conditions such as laminopathies or dystrophinopathies, or in a majority of conditions, you have a global correlation between the severity of the skeletal muscle manifestations and the cardiac manifestations, and you have correlations between the type of mutations and the severity of cardiac involvement. That is observed at the population level, but individually, if you compare small groups of patients and sometimes just in one family, you can see very different things. For example, in laminopathies, you have here the first family, which has been studied more than 20 years ago, and that led to the first description of the association between LMNA variants and emery-diffus and dilated cardiomyopathy. You had members of this family with specifically only a cardiac cardiomyopathy, and other patients with only skeletal myopathy, and some patients with both manifestations. So correlations are present, but at the level of large populations and within one family, you can see very different things. I will move on now to some of the most common myopathies. I will start with myotonic dystrophy type 1, which is the most common muscle disease in adults. So you all know that myotonic dystrophy type 1 is caused by presence of mutation in the non-coding region of the DMPK gene. The pathophysiology is complex. You have an abnormal splicing and an abnormal expression of a large number of genes, which results in a multisystemic clinical involvement. And at the cardiac level, manifestations are caused by an abnormal splicing of SCN5A, which encodes the sodium channel, canal at the cardiac level. And the main risk for these patients is the development of major conduction defects and sudden death. And the annual incidence of sudden death in this population is around, at the area of prophylactic treatments, 1% per year. And before the usage of prophylactic pacing, it was more close to 3 to 4% every year. And you can see that the risk for sudden death in myotonic dystrophy is high, and as high as in other purely cardiac inherited diseases. So sudden death prevention is a major issue in this population. Cardiac manifestations of myotonic dystrophy type 1 include mainly electrical abnormalities, but sometimes also myocardial abnormalities. And the most common manifestation is conduction system disease. When you do an ECG to DM1 patients, in more than 50% of cases, you can see conduction defects, either first-degree AV block or bundled branch blocks. Patients are also at risk for supraventricular arrhythmias, particularly atrial fibrillation, which can be seen in 10 to 15% of patients. And less frequently, patients can also have severe ventricular tachyarrhythmias, which also represent a cause of death in this population. I told you that the incidence of sudden death is now close to 1% every year. And sudden death in myotonic dystrophy patients are mainly a consequence of the progression of conduction defects to complete atrioventricular blocks, but also sometimes, far less frequently, but sometimes also to ventricular tachyarrhythmias. And this population, you can also have sometimes sudden death, mainly unwitnessed sudden death. For example, if you see a patient in the evening and you find him deceased in his bed during the night, some of those deaths can also be a consequence of pulmonary embolism, which is very often in this population, which is very frequent in this population, or sometimes respiratory problems. Patients can sometimes have dilated cardiomyopathy, which is observed in less than 5% of patients. And some patients develop heart failure, but it's not that common in this condition. So since patients are high risk for sudden death, prevention is very important. So it's very important to be able to identify high-risk patients. And since patients are at high risk for major conduction defects, the first-line treatment is implantation of pacemakers. So it's very important to be able to identify patients who are at high risk to develop major conduction defects in order to be able to offer them the prophylactic implantation of pacemakers. We know that clinical parameters, ECG and echo, can predict some death events, but unfortunately, the positive predictive value is relatively low. It has been shown in American populations and in French cohort we published ago. The only way to identify on the ECG or on the echo high-risk patients is to look for conduction defects. And we know that the wider PRS and QRS interval are, the greatest the risk for. So very basically, when you see a patient with mitochondrial dystrophy, you have different situations. You can have a patient with a normal ECG, and in that case, the risk for sudden death is extremely low, even at 5 years. So there's absolutely no indication for specific treatment. You just need to see to see patients every year or every 2 years. Some patients have symptoms and major conduction defects. For example, you can identify those major conduction defects, such as complete AV blocks on coronary ECG. In that case, this is clearly an indication for an urgent implantation of a pacemaker. And you have 1/2 of patients who have mild conduction defects on the ECG. And in that case, it's very important to figure out whether you need to implant a pacemaker or not. I told you that the ECG has unfortunately a poor predictive value, and that's the reason why a large number of cardiology groups worldwide now use an invasive assessment of conduction defects called an invasive electrophysical study. The electrophysiological study is an invasive assessment of the conduction parameters at the cardiac level. This examination can be done not in outpatients, in patients, but you just need to keep patients a few hours in hospital. It's done under local anesthesia, and you insert a probe in the groin of patients, and you push the probe until you reach the right heart, and you're able to measure several parameters. And the best parameter to predict the development of major conduction defects is the HV interval, which is considered as highly abnormal, which is above 50 milliseconds. And in this pilot study, our group showed more than 20 years ago, then when you select patients with an abnormal ECG and who have a HV interval at more than 70 milliseconds, when you implant a pacemaker in those patients, you can identify in the memories of the devices major conduction defects in almost 50% of patients. So a very high proportion of patients develop major conduction defects and would have been and are potentially at risk to die suddenly. So following the publication of this study, most cardiology groups worldwide have been using this approach. And 10 years later, we estimated the clinical benefit of selecting patients for prophylactic pacing based on the usage of electrophysical study. We compared in data from this registry, where we have more than 900 patients, the clinical outcome of patients who had an invasive electrophysical study and a pacemaker if the HV was at more than 70 milliseconds, versus another group who had only annual cardiac assessments with a ECG and a Holter ECG. And we showed that the global overall survival was improved in patients who were investigated invasively, because they are a far lower risk to die suddenly. And following the publication of this study, international guidelines issued from the cardiology scientific societies have recommended the usage of the invasive EP study in all patients with an abnormal ECG. So very basically, when we see DM1 patients at diagnosis, we firstly do an ECG and an echo, Holter ECG when patients have an abnormal ECG or an abnormal echo, and sometimes an exercise testing, particularly in young DM1 patients who practice sport, to make sure that they do not have arrhythmias at exercise. If everything is normal, patients are seen every year or sometimes every 2 years if you have a completely normal ECG and a normal echo. But if they have an abnormal ECG, then you do an EP study. And if the HV interval is below 50 milliseconds, you just need to continue with an annual follow-up. And in patients who have an abnormal HV at more than 70 milliseconds, then you implant a pacemaker, sometimes an ICD in patients who have evidence of ventricular tachyarrhythmias. And during follow-up, if patients have a progression of conduction abnormalities on the ECG or symptoms, then you can have to redo an EP study. I will move on now to the management of Duchenne muscular dystrophy, which is a completely different disease with a very different cardiac involvement. In Duchenne muscular dystrophy, the main problem at the cardiac level is the risk for patients to have dilated cardiomyopathy and heart failure. In the end, we estimate that about 40% of patients with Duchenne muscular dystrophy will die due to heart failure. So prevention of heart failure is a major issue in this population. Before the usage of all the preventive treatments we have available now, we had more than 70% of patients who had, when they reach adulthood, dilated cardiomyopathy, and with many of them having heart failure manifestations. And you can see here that the risk for patients to develop dilated cardiomyopathy mainly increases after the age of 10 years. Before the age of 10 years, you can sometimes see patients with dilated cardiomyopathy, but it's not that common. But you can have evidence of fibrosis at the myocardial level, particularly on MRI, even before that age. There's currently a recommendation to arrange ECG and echo assessments every year following diagnosis in order to be able to identify quite early myocardial abnormalities, which can lead to the introduction or increasing the number of treatments you can use to treat dilated cardiomyopathy in those patients. Initially, follow-up has been recommended every 2 years before the age of 10 years, but the most recent guidelines are more likely to recommend cardiac assessments every year. So you have two different situations in patients with Duchenne muscular dystrophy. Either patients have a normal cardiac function, and in that case, what you need to discuss, and this is the most important thing, is treating patients preventively to avoid the further development of a dilated cardiomyopathy. And you have a second situation where patients have evidence of dilated cardiomyopathy and heart failure symptoms. In that case, you just need to implement all the algorithms for the treatment of overt heart failure. So the most important thing is probably to discuss today is prevention and other preventive treatments you can use in these patients. The first drug which has proven efficient to prevent dilated cardiomyopathy and improve patient prognosis has been ACE inhibitors. ACE inhibitors represent the first-line treatment for heart failure in the general population. And we have a randomized trial conducted more than 15 years ago showing that this patient can be beneficial at around the age of 10 years when patients still have a preserved cardiac function. In this randomized trial, patients either received perindopril, which is a commonly used ACE inhibitor, or placebo. And at 5 years, patients treated prophylactically with perindopril while their cardiac function was initially normal were less likely to develop dilated cardiomyopathy and impairment of cardiac left ventricular ejection fraction. So at 5 years, the treatment was highly beneficial to prevent the development of dilated cardiomyopathy. And at 10 years, patients treated earlier with ACE inhibitors prophylactically were less likely to develop severe heart failure and had an improved overall survival. More recently, we estimated the effect of ACE inhibitors in a real-life setting in a far larger population. We analyzed data from a French multicenter registry, which includes more than 700 patients, and we compared the clinical outcomes of patients treated prophylactically with ACE inhibitors versus absence of ACE inhibitors, and we showed that the treatment was highly beneficial for the prevention of terminal heart failure and for the improvement of overall survival. Following the publication of the first ACE inhibitor randomized trial, I think there has been an international consensus to recommend the initiation of this treatment in all DMD patients before the age of 10 years. Glucocorticoids are also beneficial at the cardiac level. There's a number of retrospective observational studies, all showing that patients treated early with glucocorticoids were less likely to develop dilated cardiomyopathy and had also an improved long-term prognosis. We will never have randomized trials with glucocorticoids, particularly for the estimation of the effect of the treatment at the myocardial level, but all studies which have been conducted so far all show the beneficial effect. So I think clearly when you put patients on glucocorticoids, you do not only have a beneficial effect at the skeletal and respiratory level, but also at the cardiac level. So there's a benefit of treating patients at the myocardial level with glucocorticoids, a benefit with ACE inhibitors, and potentially a benefit with other heart failure medications. There's an ongoing randomized trial conducted in France to estimate the effect of beta blockers. So we wait a lot from this study to see whether beta blockers on top of ACE inhibitors may be beneficial to prevent the development of dilated cardiomyopathy. There has been a study conducted in the UK. It has been negative, but probably also due to a lack of sufficient statistical power. We have preliminary studies showing that eplerenone, which is also commonly used heart failure treatment, can also be beneficial to prevent the development of contractility abnormalities on MRI in these patients. And you also have, on the other hand, all the treatments you need to use when patients have overt dilated cardiomyopathy. So we have a large number of patients, and most cardiologists are familiar with the usage of those treatments in patients with dilated cardiomyopathy. Sometimes patients can develop terminal heart failure. Unfortunately, a significant number of patients still die due to terminal heart failure. In that case, unfortunately, I think it's not reasonable to offer patients cardiac transplantation project because respiratory function is significantly impaired at that stage, so it's not feasible, and it doesn't make sense to undertake a major cardiac surgery, which would be at high risk in patients with respiratory failure. But sometimes in highly sedated patients, there's sometimes the possibility to offer the implantation of a cardiac pump, what we call left ventricular assist device. Only few centers worldwide implant such devices. We do such implantations in Paris, but in highly selected patients, you can really have good results and patients can have a good quality of life. Sometimes when patients have a severely impaired systolic function, you can discuss the implantation of cardiac defibrillators to prevent sudden death. But globally, I think there's no systematic indications for ICDs in those patients, but only on an individual basis in highly selected patients who have potentially a project, specific projects such as an LVAD implantation, or who have evidence of major ventricular tachyarrhythmias, but otherwise it probably doesn't make sense to systematically implant all patients with ICDs, with an ICD when they have an ejection fraction of below 35%. I will move on now to laminopathies, which is a condition with also a very specific cardiac pattern, which is very different to what we can see in other myopathies. Since the first descriptions of laminopathies more than 20 years ago, it has been quite obvious that those patients had a very high risk to die suddenly and a very high risk for several types of arrhythmias. Particularly, it has been shown quite early that many patients had major conduction defects or severe ventricular tachyarrhythmias, even at a stage where they had still a preserved cardiac function. And sudden death represented initially by far the first cause of death in this population, and a very high proportion of patients had sudden death, mainly due to ventricular tachyarrhythmias. Laminopathies are the first condition where it has been shown that the prophylactic implantation of cardiac defibrillators, which have the possibility to terminate severe ventricular tachyarrhythmias when they occur, where there could be, it's the first condition where it has been shown that there could be an indication to place an ICD in patients in a specific condition at early stages, even before patients develop severe myocardial involvement. In this pilot study published in more than 15 years ago, in patients with laminopathy with a preserved cardiac function, the implantation of ICDs was associated with the delivery of an appropriate therapy in almost 50% of patients. And this was really the first condition where it has been shown that ICDs can be efficient prophylactically, even in patients sometimes with a preserved cardiac function. And following the publication of this study, a large number of centers worldwide have started using ICDs in patients with laminopathies, but we had at that moment no clear consensus on the best criteria to implant patients. And a few years later, there had been a collaborative study in Europe, including patients with laminopathies in a specific registry. And the specific analysis on the prediction of sudden death has shown that patients who had one of those 4 criteria were at high risk for sudden death. Those criteria were male sex, presence of a non-missense mutation, evidence of non-sustained ventricular tachycardia on Holter ECG, and an ejection fraction of below 45%, so mild left ventricular systolic dysfunction. And this study showed that patients with only one of those risk factors or no risk factor had a very low risk to die suddenly or to have malignant arrhythmias, while patients with two or more of those risk factors had a high incidence of sudden death and were potentially eligible for the implantation of an ICD. And following the publication of this study, it has been specifically mentioned in the cardiology guidelines for the prevention of sudden death in the general population that the specific subgroup of patients with laminopathies had a clear indication for ICD if they had two or more risk factors. More recently, our group has developed an algorithm to provide an even more accurate estimation of the 5-year risk for patients to die suddenly based on the analysis of our French LMNA registry called OPAL, where we have now about 1,000 patients. At that moment, we had 600 patients included. So we use data from this registry to develop the algorithm, and we externally validated this algorithm in another international population with patients from the US, Europe, Australia, and we found that the risk score predicts those events far better than the risk factor approach which I previously mentioned. And we have put a calculator online where you just need to enter patient genetic, ECG, echo, and Holter ECG characteristics, and you have very simply a 5-year estimation, a quantitative estimation of the risk. And there's now a consensus to recommend the placement of an ICD in all patients who have a sudden death risk of more than 10%. And you can see that this online calculator is now used worldwide in the US, in Europe, and in Asia very frequently to guide decisions in patients with laminopathies. So we can see that in just 20 years, we have been able to move on from the initial description of the disease to very accurate estimation of the risk for patients to die suddenly, and very subtle strategies to guide implantations for ICDs. A few words on other neuromuscular diseases. So as I told you, it's quite impossible to go through the specific cardiac pattern of cardiomyopathies we can be seen in all conditions. But we have still 10 minutes, so just a few words on the cardiac involvement in patients with mitochondrial diseases. In mitochondrial diseases, patients can develop either myocardial involvement. Generally, patients have a hypertrophic pattern with any hypertrophy of the left ventricular walls. You can see here a normal heart and see the heart of a patient with the MELAS mutation, 3243 mutation, and you can see that the left ventricular walls are thicker than in the normal heart, and it corresponds to hypertrophic, concentric hypertrophic cardiomyopathy in this patient. The hypertrophic pattern is the most common pattern, and later on, patients with hypertrophic cardiomyopathy can develop a systolic dysfunction with a reduced ejection fraction, and sometimes heart failure and terminal heart failure, which represents one of the most common causes of death in patients with mitochondrial diseases. And this is mainly seen in patients with MELAS and sometimes MERF. On the other hand, you can see electrical abnormality, which are not so common, but there's a specific genetic subgroup, the one with single large-scale deletions, which is at very high risk for major conduction defects, particularly patients with cancer syndrome. And sudden death prevention is very important in this group of patients. we developed a few years ago a very simple approach to estimate the risk for patients to have cardiovascular events. We know that when you do simple assessments such as ECG, echo, heart rate ECG, you can see abnormalities in about 1/3 of patients. And during follow-up, at 5 years, you have approximately 10% of patients who have life-threatening complications such as severe heart failure or some deaths or major conduction defects. 10% at 5 years, which is highly significant. And we have shown that just with the echo, the heart rate ECG, and the ECG, you can quite easily identify high-risk patients. And those high-risk patients are those with elder conduction abnormalities on the ECG, left ventricular hypertrophy, premature ventricular contractions on the heart rate ECG, or diagnosis of diabetes. And patients with no one of those risk factors or just are very high risk for cardiovascular events, while patients with a growing number of cardiovascular risk factors have poor outcomes and a high risk for life-threatening complications. More recently, we also showed that you can also quite easily in mitochondrial patients predict on one hand heart failure events and on the other hand arrhythmic events. And if you can see the event rate from birth in patients with mitochondrial diseases according to the type of mutation, you can see that heart failure events mainly occur following the age of 30 years in patients, particularly in the subgroup with the 3243 point mutation in the mitochondrial DNA, while the arrhythmic events almost exclusively occur in patients with single large-scale deletions. And you can see the first events in patients with current cell syndrome, events in adolescence, and the risk increases progressively over lifetime. And we have developed a quite simple algorithm to predict these events. I won't go through all the aspects of risk stratification for sudden death and for terminal heart failure, but if you go through the article, you can see that you can have a very accurate estimation of the risk for patients with mitochondrial diseases just with simple assessments with the ECG, echo, and the heart rate ECG. In patients with FSH muscular dystrophy, overall the risk for cardiac complications is very low. You can find publications made more than 20 years ago suggesting that there may be a risk for arrhythmic complications or sometimes dilated cardiomyopathy in this population. But all the most recent studies with a large number of patients suggest that the risk for cardiovascular complication is probably quite similar to that in the general population. Patients with LGMDs are also at high risk for cardiac complications, particularly for dilated cardiomyopathies, particularly patients with sarcoglycanopathy. The risk is probably the greatest for patients with delta and beta sarcoglycanopathies. Patients with dystroglycanopathies, and particularly those with FKRP mutations, have a high risk for dilated cardiomyopathy. And very similarly, patients with titinopathies are high risk for mainly dilated cardiomyopathy. Some conditions are highly arrhythmogenic, with sometimes specific indications for the implantations of pacemakers or more frequently ICDs, cardiac defibrillators, because the risk for ventricular tachyarrhythmias is also high. Desminopathies, among those desminopathies, represents one of the most severe conditions. You have more than 70% of patients over lifetime who are at risk for developing complete atrioventricular blocks. And it's very important notice that following complete AV blocks, patients have also a high risk to develop ventricular tachyarrhythmias. So if patients have complete AV blocks in these myopathies, you should not implant pacemakers, but rather cardiac defibrillators. This is one of the most important messages. Patients with myotonic dystrophy type 2 have very similarly to patients with DM1 significant risk to develop complete AV block, but the risk is lower than in DM1, and conduction events generally occur later in life. In DM1, it's on average 40, 45 years. In DM2, it's more 70, 75 years. FHL1 patients and vitamin C, particularly when you have truncating mutations, are at high risk for sudden death. And you also have indications for prophylactic implantations of ICDs. Patients with amylinopathies have a very high risk for complete AV blocks, but also ventricular tachyarrhythmias. And generally, patients develop severe conduction defects quite early, when patients at age 20 or 30. And in that case, there's an indication to implant an ICD and not a pacemaker, because following the placement of a pacemaker, unfortunately, some patients still die suddenly due to ventricular tachyarrhythmias. And very importantly, when patients with amylinopathies have evidence of atrial fibrillation, even if they do not have specific risk factors for stroke, there's a very important indication to put patients on oral anticoagulants, because the risk for ischemic stroke is extremely high in these patients. So in conclusion, globally, patients with neuromuscular disease are at high risk for cardiac complications, which represent, for many conditions, one of the most causes of death, and the morbidity is also great in these populations. And to improve prognosis, it's important to be able to diagnose early abnormalities and to offer patients prophylactic strategies for the prevention of sudden death and terminal heart failure. In myotonic dystrophy type 1, the most important thing is to implant prophylactically pacemakers to prevent sudden death. In Duchenne muscular dystrophy, it's very important to prevent terminal heart failure with treatments such as ACE inhibitors and potentially other heart failure treatments and glucocorticoids. And in arrhythmogenic conditions such as laminopathies, desminopathies, laminopathies, you have indications for cardiac defibrillators. So it's very important at diagnosis and during follow-up repeatedly to estimate the risk for patients to have the ventricular tachyarrhythmias and to implant ICDs early for the prevention of sudden death. Thank you for your attention. I think we have 10 minutes for questions.
Thank you, Karim. Quite a complete and very extensive review of the problems of these patients. I'm going to, so we have a question from Deepti Bhaskar that wonders what is the role of cardiac MRI in these cases, and I will unmute Deepti so that in case there is a will to dialogue directly with you. So what do you see a role for MRI of the heart for this kind of evaluations or not?
Yeah, obviously cardiac MRI has an added value compared to the echo, because sometimes you can monitor more accurately the systolic function and the ejection fraction. And most importantly, you're able to identify fibrosis, particularly in the left ventricle. And we know that fibrosis burden is correlated to a further impairment of cardiac function, heart failure events, but also sometimes arrhythmic events. So in conditions at risk for heart failure, such as Duchenne muscular dystrophy or Becker muscular dystrophy, it can be useful to have an MRI done, at least at diagnosis, and perhaps every 3 to 5 years to monitor the fibrosis burden. And sometimes it can help guiding decisions to put patients on heart failure treatments. And on the other hand, in conditions at risk for some deaths with arrhythmogenic cardiomyopathies, probably it has not been validated for all conditions, but we have preliminary data in laminopathies, for example. The fibrosis burden is probably correlated to the risk of ventricular tachyarrhythmias. So it can also sometimes be useful to have an MRI done when you have decisions for ICDs, if patients have an intermediate risk and you're not sure if you should implant an ICD. If on MRI you have a lot of fibrosis, it can be sometimes that can suggest that you should place an ICD.
Excellent. So Dipti, if you're satisfied, that's all right. Otherwise, mute yourself. And so Dipti seems satisfied. Very well. Catherine asks about withdrawal of corticoids in Duchenne patients that are fully dependent of non-invasive ventilation. It's the same for you, Catherine. If you want to voice your question, you're free to unmute yourself. Karim, what do you think about that?
Well, I think things are quite clear for the first years of glucocorticoids in Duchenne, particularly when you start the treatment in ambulant patients and while patients are ambulant. All the data we have at the myocardial level for the benefit associated with glucocorticoids are derived mainly from studies where the treatment has been started early. But we do not have so many data regarding patient outcome, particularly at the cardiac level, following loss of ambulation. Probably or possibly, prolongation of glucocorticoids may result in a prolonged benefit at the myocardial level, but it's not that clear, and it will be quite difficult to demonstrate. And there's a great heterogeneity regarding the clinical practice for the usage of glucocorticoids following loss of ambulation. I think preservation of the cardiac function can be an argument for a longer follow-up duration, but it remains speculative. So I think decisions have really to be made on an individual basis based on the estimation of the benefit-risk ratio. If you have a lot of adverse events following the usage of glucocorticoids, such as osteoporosis and spinal complications, then probably the ratio between the benefit and risk is not in favor of using glucocorticoids. But otherwise, if the treatment is quite well tolerated, preservation of myocardial function can be a reason for treating patients for a longer period of time. But it's a very difficult question.
Well, I hope Catherine is satisfied. Otherwise, just unmute yourself, please. So I would like to put a question myself, and it has to do with wearables. So you were one of the doctor specialists that have been using wearables for a longer time with your loop recorders, etc. But nowadays people have watches and things that record their digital pulse and sometimes even their ECG. And I was wondering if you think, first of all, if you came across a situation where data from wearables changed your reasoning, or if you came across any evidence that they can be soon used also for the long-term follow-up of these patients.
Sorry, I just lost your last sentence, but I think it's a very important question. You're completely right. There will be obviously a growing place of such devices in the future, particularly in arrhythmogenic conditions, conditions at high risk for conduction abnormalities, supraventricular and ventricular arrhythmias. We have preliminary data with devices such as loop recorders, and I think you obviously increase the ability to diagnose early ventricular events, because before the development of complete AV block or sustained ventricular tachyarrhythmias, a majority of patients have before that shorter events. And if you diagnose those events and you treat patients prophylactically just a few days following the diagnosis of those paroxysmal events, then you can prevent some sudden death events, obviously. So I have seen that for several patients, particularly with laminiopathies, when patients have an intermediate risk. They do not have an indication for ICD, but on the other hand, they have significant abnormalities and you do not feel comfortable with only having an ECG every 6 months. Then you place subcutaneous devices, and in some cases, we have implanted ICDs following specific diagnoses because we had implanted the loop recorders. Loop recorders, we have a certain degree of validation now also in the general population. And we will use more and more of those devices in the near future. And on the other hand, you have all, what you mentioned, or the watches and all the things such as the Apple watches that you can buy. And we have a study published in the New England Journal of Medicine a few years ago with Apple watches showing that you can improve the ability to diagnose paroxysmal atrial fibrillation. And I think obviously in the future, we will improve patient management with those devices. We probably need validation in that we need to know what it really means when patients have short arrhythmias, because at the moment, the validation we have is based on the analysis of data with a short duration of time. If you have AF on the Holter ECG for 24 hours, it probably does not have the same meaning as having just 1 minute of AF with your Apple Watch over 1 year. The meaning is probably not the same, but we need validation to see what it really means and what therapeutic approaches should be implemented based on the identification of those. And we need to do research, clinical research, to validate that. But obviously, there's a huge potential to improve patient management and perhaps to prevent sudden death.
Okay, it seems that we've reached the end of the questions and also the end of our time. Thank you very much once again, Karim, for your kind intervention and participation. As everybody knows, these webinars are made available on our website after some time of being diffused, and so you can review the discussion later if you want. And I hope to be meeting you very soon. I'm sure I will. And thank you very much. Thank you
very much for your invitation.
And please fill the form, namely if you want a certificate, and if you don't want a certificate of attendance, you still could send us your precious feedback and we'll be very thankful. Bye now.